Hey guys, I'm Tony Tian, and if you're new to this channel, I'm a second medical student at University of Otago. So today what we're going to be talking about is a summary for the treatment of rheumatoid arthritis, RA. So if you don't know rheumatoid arthritis, in brief, it is a chronic inflammatory autoimmune disease, and it has a prevalence about 0.8% worldwide, 3 to 5 times more common in female. Onset usually occurs between 30 to 55 years old and is disabling and painful. And basically, the essential pathology is that your immune cells basically is thinking your joint cells are basically they think your joint cells are a foreign invading antigen, and they're attacking your own joint pretty much. And basically you get damage in your cartilage and in between your joints, and then your body is trying to heal it by forming granulation tissues and making fibrous connective tissue. But then what's going to happen is that your autoimmune complex, your autoimmune body in your body are just gonna keep trying to attack your joint, and your joint is keep trying to repair itself, but it can't really fully repair itself before the attack starts again. So overall, you form this structure that is very famous renowned for this for rheumatoid arthritis, and we call it penis. And basically it just abnormal fibrovascular tissue, basically a mixture of your immune complex, your granulation tissue, and your fibrous repair, and the original bone that has been eroded, right? And basically you get distortion in your joint a lot. So basically the treatment for RA, we don't have a complete treatment that can stop the autoimmune response, stop the antibody in your body from attacking your own joint. But what we can do is we can sort of dampen down the activity of your immune system, so we can sort of have a systemic suppression on your immune system, so it doesn't destroy the joint as much. And the current treating method, the current treating solution, sort of to try to slow down the disease progression as much as possible and allow some of the side effects of the drugs. Alright, so the three main types of drugs that we're using are the glucocorticoids, the NSAIDs, and the DMARDs. Alright, so we're gonna talk about the NSAIDs first, just because they're like the most straightforward, easiest to understand, non-steroidal anti-inflammatory drugs. And basically they're enzyme inhibitor that inhibits the COX, the cyclooxygenase, that converts arachidonic acid into there are people outside. Yeah, converts arachidonic acid into prostaglandin, and basically if you inhibit that, you inhibit an entire inflammatory pathway that you just sort of dampens down the activity of macrophages, endothelial cells, mast cells, and platelets. Right. So a common NSAID is ibuprofen, and basically it's more potent than aspirin. And also another fact that is it's a reversible NSAID, so it doesn't bind to the receptor covalently. It's a non-covalent bond, so it's reversible. And another one you're using is very common, it's called the diclofenac, and basically it's more potent than ibuprofen, but has a higher risk of GI effects like GI bleeding because on the NSAIDs, because as I mentioned, it inhibits all the inflammatory pathway, which includes the platelets, which is coagulation pathway. So basically you tend to get more bleeding. And you have the oral and the topical formulation. And basically if it's topical, you have less systemic side effects. So the main point of this drug is to reduce the pain and the inflammation, but it doesn't really affect the disease progression, and it's usually useful during the first couple of weeks during the diagnostic workup. So it's sort of like a bridging therapy to initiate the DMARD. And you usually have two forms, the COX-1 inhibitor and the COX-2 inhibitor. The COX-1 is the constitutive isoform, and the COX-2 is an inducible isoform. And basically the difference between the COX-1 and the COX-2 enzyme is that the COX-1 is sort of always active, and the COX-2 is inducible, so it's only active at some times, which means it's more for the inflammatory, because as you can imagine, it only gets activated when there's a trigger, and for things like your gastric and renal system, it sort of needs the COX-1 to be active all the time, whereas inflammation is something, a progress that only needs to be activated when there's a foreign antigen come in. So the inhibition of the COX-2 receptor is more important, and it counts for the anti-inflammatory effects. So basically, we want a drug that's more selective towards the COX-2, such as the diclofenac, but we also have other drugs like the celecoxib, which are like so one of the drugs' name is the Celebrex, which is highly COX-2 selective, and they're basically it has a much better look when it comes to the incidence of the GI effects, of the gastrointestinal side effects. But another thing is that it increases the risk of the CV events. It sort of triggers the thrombus formation, and it's currently a off-the-shelf drug, and the prescription is only for symptom control of the rheumatoid arthritis, but it's very, very effective. And other than that, we have the glucocorticoid, which is secreted by the adrenal cortex and alters the gene progression to reduce the effects. And basically, what this one inhibits is the PLA2, which converts the phospholipids into the arachidonic acid. And the PLA2 stands for the phospholipase A2. Okay, and it is also a bridging therapy to control the symptoms until demand and effective. Some of the side effects are like Cushingoid effects, so weak muscle, bone and skin problems, etc. Some of the common ones, you have the dexamethasone, which is a very strong anti-inflammatory drug. It's used for many inflammatory and overactive immune system conditions, but it's not really being used in RA today. And then you have the prednisone, which is the main glucocorticoid for RA. It's widely used for many other inflammatory and immune conditions as well. The side effects are common. And the other one is you have the triamcinolone acetonide, which is a intra-articular injection one, so it goes straight into your joint. So it's more targeted, and it interferes with the tissue regenerating. So that's the side effects. Okay, and now we come to the DMARDs. So basically what DMARD stands for is the disease-modifying anti-rheumatic drug. So as you can hear from the name, it is very, very specific to the rheumatic kind of condition. And it is highly immunosuppressant, which is something we want in this case because we have an overactive immune system. All right. So most of the DMARDs still works in this unknown action, and some of them are better understood, and some of them are literally just being discovered by accident, kind of like penicillin. Okay. So basically, the DMARDs have slow onset of action. It takes weeks to months to actually take effects, which is why we need the NSAIDs and the glucocorticoid to sort of being used first as a bridging therapy, and all of them causes immunosuppression, so it increases the risk of infection for the patient who are taking it. So as doctors, we always need to monitor the blood cells, and several also used as immunosuppressants for other conditions, like when you get a body organ transplant. Okay. So some of the examples, some of the really common ones are methotrexate, which is the most commonly used drug for rheumatoid arthritis so far. And these are also cytotoxic agents, which are also being used in chemotherapy. So they do have a lot of side effects. But basically, its idea is to dampen down the disease progression as much as you can and just allow the side effects to happen under a tolerable standard. And then you have the cyclophosphamide. and there were many other ones that are being used historically, and we're not going to mention here. So methotrexate is the first choice of DMARD. It's low cost and it's effective. It's used in patients with RA and in some cancer patients as well. Quick onset of action than other DMARDs, so you usually take 3 to 6 weeks. It's still long, but it's much shorter. It has many side effects like mucosal ulceration, hepatic skin reactions, nausea, and alterations to blood counts. The main action is that it's a folate antagonist, which is a kind of amino acids that's being amino acids being required for the production of the nucleotides, and therefore is important for the DNA. And therefore the DNA is not being produced properly, and you have the apoptosis of the cells, and that's sort of how you achieve this suppression on the immune system, because it's sort of targeting the dividing cells, the bone marrow cells, the progenitor cells in the immune system, and the tumor cells. Basically restrict the panels from growing excessively and causing massive swelling in the joint and taking up too much space. Alright, and it's also being used as immunosuppressants for other indications, and it suppresses activities of the immune system by targeting the cells of the immune system, bone marrow progenitor cells, and differentiated immune cells, the cytokine release, the circulating cytokines. Okay, and you have another kind of drug which is called the Cyclosporine, and it's also being used to prevent tissue rejection. It inhibits the calcineurin, which is a phosphatase that activates the T cells. So basically, it decreases the T cell proliferation, inhibiting interleukin 2, which is kind of cytokine. So if you think about it, it's actually kind of similar to the HIV virus, but basically it just dampens down your immune system. So it does have side effects, many serious, some serious ones, including hypertension and renal toxicity. All right, and then you have other biological DMARDs, which has less systematic effects, and the focus is more on the individual chemicals that has been produced by your body, like infliximab, which targets the TNF alpha, and the rituximab, which is a monoclonal antibody against the CD20, which is primarily found on the surface of B cells, which it destroys. So basically, by that you're turning off the B cells, and therefore you're dampening down the immune system. And you also have other drugs targeting interleukin 6. Some of the other ones also depletes B cells, like our rituximab. Alright, so that's everything I want to talk about the treatment for rheumatoid arthritis today. And if you have any more questions, just leave it in the comment section below, and don't forget to hit the like button and subscribe to the channel, and I'll see you next time. Bye!